Welcome to the deep dive. We are jumping straight into something pretty specific today, but really high yield, especially if you're in the middle of medical revision.
Absolutely.
And this deep dive is actually based on revision notes you shared with us, focusing on a particular pediatric condition, gastroschisis.
That's right. So think of this as like a focused revision session. We're going to go through these notes you sent, pull out the absolute must-know stuff about gastroschisis, and, really try and make it stick.
Exactly. Our mission is basically to unpack these notes,
Yep.
make sure you leave with a really clear, kind of memorable picture of what gastroschisis is. At its core, it's a congenital abdominal wall defect. So something present at birth where the baby's tummy wall hasn't formed quite right.
Yep.
We're going to cover everything that the notes mention, the definition, causes, risks, how it happens, what else it might look like, how common it is, the clinical picture, investigations, management, prognosis, and potential complications.
And for revision, focusing on things like this, it's all about the key differences, the main associations, the core management principles. We'll definitely zero in on those.
Okay, let's start with the definition then. The notes say it's a congenital abdominal wall defect. What does that actually mean in the case of gastroschisis?
It means there's basically a hole in the abdominal wall. And a really key detail the notes highlight is where it usually is typically just to the right of the belly button, the umbilicus.
Right. And because there's a hole, the stuff that should be inside isn't.
Exactly. Abdominal organs, mostly bowel, protrude. They spill out through that opening.
Now, here's something the notes really stress, and it's crucial for exams. The big difference between this and something like Exomphalos.
Yes, absolutely critical. With gastroschisis, there is no covering membrane, no sac over those protruding organs. They're just exposed to the amniotic fluid before birth and then the air after.
Okay, so no membrane is the absolute key if you're trying to remember this. Maybe think gastroschisis, G for C. Well, maybe guts out, and the spot is usually to the right. So gastroschisis, guts out, right side, no cover.
Yeah, that works. That membrane difference or lack of membrane is honestly the biggest thing to remember for telling them apart.
Get that clear, and you're sorted on basic identification.
Pretty much, yeah.
All right, so we know what it is. The next big question is why. What do the notes say about the causes, the etiology?
Well, the notes are pretty upfront. The exact cause, unknown.
Ah, okay. A classic, we're not entirely sure yet. But they do give some idea about the process that goes wrong.
Yeah, the general thinking is it's some kind of disruption early on in pregnancy in how that abdominal wall normally develops and closes up.
So the trigger's a mystery, but we know when it happens early fetal development and what's interrupted that normal wall closure.
Exactly. And, that leads people to look at factors that might increase the risk of that disruption happening.
Which leads us nicely into risk factors. What specific things do the notes flag for gastroschisis?
Okay, so they list a few key ones. Young maternal age is mentioned.
Interesting.
Yeah, also maternal tobacco or drug use and maybe certain environmental factors, though those are less specific.
And importantly, the notes also add that it can just happen,
Yeah.
right? Even without any obvious risk factors.
Definitely. It's not always a clear link. And while we're on associations, the notes mention other abnormalities can sometimes occur alongside gastroschisis. About 7 to 30% of cases, they say.
What kind of things?
Things like anencephaly, cleft lip and palate, ectopia cordis, that's the heart being in the wrong place, and then more gut-related stuff like intestinal atresia, malabsorption, even appendicitis. Prenatally, polyhydramnios, too much amniotic fluid can be associated too.
Okay, so mostly structural things or gut issues. And this is another key point compared to Exomphalos, isn't it? The notes suggest Exomphalos is linked to different types of problems.
Exactly. The notes point out Exomphalos has a much higher link with chromosomal abnormalities like trisomy 13, 18, 21 and syndromes like Beckwith-Wiedemann. Right. So while both can have associated issues, the type of issue is often a big clue. Think genetic syndromes for Exomphalos, more often structural or gut problems with gastroschisis. Remembering that helps with the differential.
That's a really useful distinction for revision. Okay, quickly then on pathophysiology. How does the hole actually form?
Well, the notes basically say it's down to incomplete closure. The different layers of the abdominal wall just don't fuse together properly during development.
And the result of that failure to close?
Is that the abdominal organs herniate, they push out through the defect that's left behind. Simple mechanics, really. A structural opening leads to stuff coming out.
Got it. Okay, let's switch gears to differential diagnosis. Super important for exams. What else could this look like, and how do we tell them apart based on these notes?
Right. So the main ones you need to differentiate are omphalous sling, exomphalos, and we've hammered that membrane difference, right?
Right. Membrane versus no membrane.
And also umbilical hernia.
And the notes also list a few other possibilities, things that might present as an abdominal wall issue, like physiological bowel herniation, amniotic band syndrome, bladder exstrophy, limb-body wall complex, some vascular things like hemangiomas, and pseudoomphalocyly. Quite a list.
Yeah, but the real focus tends to be gastroschisis versus exomphalos. So remember our little memory aid? Gastroschisis usually, right, no membrane. Exomphalos, usually midline at the umbilicus, has a membrane or sac, and often linked to those genetic syndromes.
Okay.
If you can nail those differences, location, membrane, common associations, you're in a really good position.
Perfect. If you get asked to compare, hit those 3 points. Location, membrane, associated problems. Okay, numbers time epidemiology. How common are we talking?
The UK prevalence mentioned in the notes is around 1 in 3,000 live births.
Okay. And the notes mention something slightly concerning the trend seems to be increasing?
Yeah, they mention an increasing incidence in recent decades. U.S. data cited shows it going up to maybe 4 or 5 per 10,000 live births over a 25-year period. They do add a note that estimating this precisely is tricky because of elective terminations.
Right, that makes sense. And the notes bring up that prognosis point again.
Yeah.
Gastroschisis usually being a single defect, generally good prognosis, versus exomphalos, which carries higher risks because of those potential chromosomal issues and other severe conditions.
Yeah, it reinforces that distinction. Interestingly, though, the notes then list some risk factors that seem to be shared between both conditions.
Oh, like what?
Things like placental insufficiency, maternal illness or infection, drug use, smoking, young maternal age again, substance use, even maternal hypothyroidism. So there's some overlap in the background factors, it seems.
Okay. Good to know. Let's visualize it then. Clinical features. What does a baby with gastroschisis actually look like when they're born?
Well, the main thing, as we've said, is the protrusion. You see intestines, maybe other abdominal organs outside the abdominal cavity.
And where are they coming out from?
Typically just to the right of the umbilicus. The notes describe the opening itself as usually pretty small, less than 5 centimeters, right next to where the cord inserts.
And the notes add an interesting point that connects back to those associated abnormalities we talked about. Externally, you usually just see the defect, right? No other obvious external abnormalities typically.
Yeah, that's a good clarification. While there might be internal issues, the external picture is usually just that specific abdominal wall defect with the exposed organs. That's the classic presentation you'd see.
Okay, so you see that picture. How do you confirm it? What investigations are key, according to the notes?
They break it down into labs, imaging, and procedures. For labs, maternal serum alpha-fetoprotein MAFFP is important.
Right, and the notes point out it's raised in both gastroschisis and exomphalos, but it's typically higher in gastroschisis. That's quite a useful lab finding, potentially.
It can be, yeah. Karyotyping, checking chromosomes is also mentioned. But again, the notes emphasize this is particularly important if exomphalos is suspected because of that link to chromosomal abnormalities.
Makes sense. And imaging. Ultrasound is the big one.
Absolutely. Ultrasound is the main tool, usually done prenatally. It can identify the defect and, crucially, help differentiate between gastroschisis, exomphalos, and those other possibilities. MRI might sometimes be used maybe to get a better look at liver position.
And again, the notes list other imaging tests, renal ultrasound, echo for the heart, sacral x-rays, but specify these are often more relevant for exomphalos cases to actively look for those associated problems. It keeps coming back to those key differences.
It really does. And same for procedures like amniocentesis for genetic testing. The notes say it's indicated if the AFP is high and the ultrasound looks more like exomphalos, the whole investigation pathway kind of reflects the different risk profiles.
Got it. So quick revision check. Which prenatal lab test is usually raised and often higher in gastroschisis than exomphalos?
That would be the maternal serum alpha-fetoprotein, MSAFP.
Perfect. Okay, diagnosis is made. What next? Management. How is gastroschisis handled? The notes talk about the UK approach.
Yeah, it's very much described as a multidisciplinary effort, needs lots of different teams involved. It covers stabilizing the baby before surgery, the surgical repair itself, and then careful postoperative care.
And an interesting point from the notes, the diagnosis itself doesn't automatically dictate how or when the baby should be delivered.
Right. Now, for the repair, the notes mention a couple of techniques. There's plastic closure, often using what's called a temporary silo.
What's that?
It's basically a sterile bag or covering placed over the exposed organs. It protects them and allows them to be gradually pushed back into the abdomen over several days as swelling goes down and space allows.
Ah, okay, like easing them back in gently.
Exactly. The alternative is primary closure, where they stitch the defect closed straight away. Sometimes that might be delayed a bit if the baby isn't stable, there's too much swelling.
And before surgery, there's that crucial stabilization phase.
Yes, absolutely vital. Managing potential breathing problems, preventing heat and fluid loss from the exposed bowel, that's a big issue. Giving antibiotics to prevent infection.
Makes sense.
And nutrition is key too, usually parenteral nutrition, feeding through a central line, because the gut won't be working properly at first.
Well,
They also mention monitoring urine output closely and sometimes needing rectal dilation.
okay. And the timing of the repair, the notes suggest immediate or waiting a few days, up to 5 days, seem to have pretty similar outcomes.
Yeah, that's what the notes indicate. It really highlights why you need that whole team: surgeons, neonatologists, specialist nurses, dietitians, all working together.
Absolutely. So looking further ahead then, prognosis. What's the general outlook for these babies?
The notes state that generally the prognosis is favorable, assuming they get the right management. But it does depend on a few things,
Like what?
like the size of the initial defect, whether there are complications along the way, and just the baby's overall health.
And what factors might suggest a poorer prognosis?
The notes list things like bowel-related complications. We'll get to those: being born prematurely, having other significant gut issues, or having other non-gut-related anomalies.
Right. So let's talk about those specific complications. What can go wrong, according to the notes?
A big one mentioned is intestinal atresia, basically a blockage or narrowing in the bowel. The notes say this happens in about 10 to 20% of cases.
Okay, that sounds significant.
It is. Also problems later on, like malabsorption syndromes or just ongoing intestinal dysfunction after the surgery.
And the surgery itself can cause issues.
Yeah, the notes warn that if the closure is too tight, it can actually put too much pressure inside the abdomen. That can compromise breathing, heart function, blood flow.
Wow, okay. A delicate balance.
Definitely.
Yeah.
And lastly, there's the risk of short bowel syndrome. This can happen if a significant amount of bowel is damaged, maybe due to poor blood supply or from complications like atresia, and has to be removed.
Right. So those complications, especially the bowel ones, can have really long-term impacts on feeding and growth.
Exactly. Understanding those potential hurdles is key to anticipating the longer-term care these children might need.
Okay, let's wrap this up for revision. We've done a real deep dive into gastroschisis based on your notes. High-yield points to take away.
Mm-hmm.
It's that congenital abdominal wall defect, usually to the right of the umbilicus, no covering membrane, remember, right, no cover.
Mm-hmm.
Key differential is Exomphalos midline, has a membrane, linked more to genetic syndromes. Gastroschisis associations tend to be more structural or gut-related. Investigations. Ultrasound is key prenatally. MSRA is usually high. Management. Multidisciplinary stabilization, then surgical closure, often with a silo first.
Yeah.
Prognosis is generally good, but watch out for those bowel complications like atresia or later dysfunction.
And when you're revising, try picturing a clinical scenario, a description of a newborn.
Yeah.
Use those key features: location, membrane, lack of membrane, to differentiate. That really helps lock it in.
Definitely. Okay, so building on that point from the notes about the increasing incidence, here's something to think about after this session. Given that gastroschisis seems to be becoming more common, what factors beyond the known risks, like young maternal age or smoking, might be playing a role? And, how might understanding this changing trend affect prenatal care or research priorities in the future? Just some food for thought.
Yeah, interesting question. So that brings our focus dive into these gastroschisis notes to an end. We really hope going through it like this has helped clarify things for your revision.
Yeah, absolutely. Thank you for sharing the material that let us do this deep dive just for you. Seriously, best of luck with the MSRA prep.
And if you are looking for more resources, like maybe more high-yield notes like the ones we discussed, definitely check out PassTheMSRA.com.
And don't forget, there are also free resources available over at freemsra.com.
Keep up the great work with your revision. You can do this.